Let's talk about the subjective. So a patient comes into you and might complain of shoulder pain. Talk to us a little bit about what gives you clues within that patient's subjective history about what's going on around the shoulder or the scapula.
So the first thing we do, I think, is always look what the actual irritability is of the structures by asking them whether they have only pain during activity or also during rest. So very often when you have overhead athletes, for instance, it's very subtle pain. They only have pain during sports activity, not during rest, and even not during normal daily activity. So that's the first thing. So because when you have high irritability, you will never exercise during the first session. When the irritability is low, we have to find where the cutoff value is for the patient for the exercises to prescribe. The second thing I think is I always look at the localization of the pain that the patients tell me. Is it really in the arm? But then they say, it's in my arm, it's not in my shoulder, or is it more in the cervical area or in the muscle area around the scapula? So when they say I have pain in the arm, for me it's a shoulder patient, probably with some scapular dyskinesia or thoracic and cervical spine disorders. But if they have pain, let's say more in the trapezius area, I look at them more as a neck patient or a really scapular patient. Some patients, they have pain in the scapular area because probably they overload their muscles because they're weak or dysfunctional. So I look a little bit at the location of the pain. And then, of course, the expectations of patients. It's a big difference whether you have, let's say, someone who is not really active in overhead sports and who is not really sports active in any sports compared to someone who needs to be prepared for, let's say, world championships in 4 weeks. So the expectations also very important.
When do you start to look at the scapula as opposed to the glenohumeral joint? So obviously you're looking at pain in the arm. You go, okay, well, we're thinking now maybe some more cervical spine or scapular stuff. Whereas if they're talking about pain over that traps or shoulder, that's when you're going to start to explore that glenohumeral joint. Is that right?
Yes, well, after the subjective history, I always start with the basic clinical shoulder exam. So if you ask me when do you start to look at the scapula, it's from the first second, because when you do active movements into forward flexion, abduction, of course you ask the patient, is it painful or not? But I already observe scapular function and I do side-to-side comparisons. I try to find out the 3 types of scapular dyskinesia, and I also look at visible muscle activity. For instance, do we see hyperactivity in the upper trap? Do we see hyperactivity in the rhomboids? These muscles very often are hyperactive in these patients, and there's not a lot of research done on that. We're working on that at the moment, but the muscle is very hard to capture because you need a fine wire EMG. And then, of course, during these movements, I always look at the scapula, but I do the full shoulder examination, even if the patient comes to see me with some more spine or scapular related pain. So I can rule out glenohumeral pain. And then after that, when there is not at all any shoulder pain, I skip to the scapula. When they have some pain patterns that might be the reflection of impingement symptoms, I go on to the impingement algorithm to find out whether on any level there is a connection between the scapula and the actual shoulder complaints. And then, of course, when the patient has more scapular related problems, I really focus on the assessment of the scapula.